It is well known that children are allowed to have at least a cough every month. That is about 8 to 12 episodes per year. But however, some children get to have cough longer than expected. Usually a cough clears within a week, whether treated or not cleared or treated. But for some children, these coughs last more than a week, up to 2 weeks, up to a month, and sometimes even more than a month. The question is, what really causes these prolonged coughs? For some of them, the coughs are seasonal. They happen during the rainy season, they happen in the mornings and in the night, and sometimes cause a lot of absenteeism in the school times and less productivity on the side of the mother, because no one can afford to leave their child that is coughing so much to go and chase the boardroom. But the question is, are all these coughs innocent? Well, last time we introduced the subject of asthma in children, and we clearly discussed what really asthma is, what causes asthma, what are the risk factors of asthma, and basically how can we identify a child that is living with asthma, that is the signs and symptoms of asthma. Welcome to the Pediatric Voice. I'm your host, Dr. Helen Namsoke, and we are here to discuss this week to complete the subject of asthma, and we are mainly going to tackle that is the diagnosis of asthma. How would we tell that a child actually is asthmatic, and then how best can we manage a child living with asthma? Remember, so many times our children get to miss their school days. Sometimes children miss out on their life. They may not engage in the day-to-day activities children do enjoy, like sports, swimming, singing, and so many other activities because of the limitations of their breath. So we are going to tackle the subject of how best can we improve the livelihood of our children to make sure that they enjoy their life to the fullest despite being diagnosed with asthma. And what if your child gets an acute attack? What can you do as a parent out there to make sure that your child lives? Remember, about 10% of our children, especially those less than 5 years, are living with asthma, and about 90% of children, by the time they make their 5th year of life, they've had a wheezing episode. So our pediatrician this evening is going to teach us on how best to deal with a child with a wheezing episode, and so much more. We'll give the number on our screen, and you'll be allowed to share in your comments, as well as call in to ask your questions so that we discuss this subject in detail. But before we go into the discussion, let's have the guest.
Dr. Elizabeth Kutamba, a consultant pediatrician, medical director and proprietor Health Haven Clinic, a member of Uganda Pediatric Association, a Deputy Director for East African Center for Vaccination and Immunization, a member of the Tobacco Control Advocacy Committee, a member of the STAMP, Strengthening Asthma Management, a child health advocate, passionate about school health issues.
So this week we have Dr. Elizabeth Kutamba again, who taught us last time, gave us an introductory bit about asthma, and she's here to discuss the subject in detail. Thank you for accepting our invite, Doctor.
Thank you, Dr. Helen. Good evening, viewers, and I'm very happy to be once again invited at Bethany TV. So it's my pleasure to be back. And just right before I came yesterday, I had a patient who said, "Oh, I saw you at Bethany, and I felt whatever you described, my child has." So I felt, wow. So there's someone who is being touched out there. So that's the more reason I was excited to be back so that we complete our topic regarding childhood asthma. So I'm very happy to be back.
Thank you very much, Doctor. Thank you for allowing to teach the nation and improving the lives of our little ones. Thank you all that tune in to Bethany TV, and especially to the Pediatric Voice, a show where you are learning so much about your child's health and how best to improve the livelihood of your little ones. You can watch Bethany TV for Health on channel 841, that is on Go TV, and channel 170 on Free to Air. On Bethany TV Uganda, that is on Facebook, X Spaces, as well as on YouTube. Feel free to call in your friends, all the parents that you know, to share that link to them so that they can watch and learn more about their children's health. But before we go deep into the discussion, let's have first a documentary on asthma.
Asthma is a chronic lung disease, often of genetic predisposition associated with narrowing and swelling of the breathing pipes. It is characterized by recurrent or seasonal coughs, whistling breath or wheezing, chest tightness, chest pain, and difficulty in breathing. Asthma is the commonest non-communicable disease affecting both children and adults, with about 262 million people affected and 455,000 annual deaths. Asthma affects about 1.9% of children of under 5 population, with about 38.7% of children living with asthma suffering at least one attack annually. Uncontrolled asthma is associated with sleep disturbance, interrupted daily activities like sports, school absenteeism, poor weight gain, and poor development. Efforts to improving diagnosis, treatment, monitoring, and control of asthma has immensely seen to be a success in improving the quality of life of children living with asthma, as well as reduce childhood mortality and morbidity.
So, Dr. Elizabeth, from the documentary, you've clearly seen a number of our children get interrupted lives. Some of them miss their school days, their sports days, their drama days because of unwellness in terms of coughing, wheezing, and so many. What do you have to tell the public out there?
That's very important, and no wonder. It's the reason why we really want to discuss about asthma, because it's a dream of every child that when they go to school, they complete whatever level of education they are at. And it's also a wish that if a mother or a parent takes this child to school, they would wish less to be called that your child is sick or they are coughing. And worse still, if they are going to be in hospital almost every 2 weeks, every month, every day, because of cough, because of, the cough that doesn't end. So it is important that when we address this issue of asthma, we manage it well, then everybody's happy. The child is happy at school, there are no miss outs and dropouts of school. The parent is able to perform at work, and the child can sleep comfortably, can participate in school activities without any worries, and everyone is happy. And of course, the burden of disease, the mortality, the deaths that come associated with some of these asthma-related, illnesses, it's also handled, it's also limited. So yeah, it is important that we talk about childhood asthma.
Thank you very much, Doctor. So last time you clearly defined asthma to us as a chronic condition that is basically genetic in nature, that is, it is born with, and then there is usually a trigger from the environment that sparks off a reaction in the lungs, and especially in the breathing pipe.
Yes.
And then we get narrowing of the breathing pipe, and then sensitivity of the breathing pipe, secretion of water or fluid in the breathing pipe, and eventual difficulties in breathing.
Yes, a restricted airflow.
And restricted airflow. So in other words, air cannot easily go in and go out. Thank you very much. And you tackled the signs and symptoms of asthma.
Yes,
but being the fact that we are going to look at management of asthma today, I would want you to give our viewers out there a little bit of a recap of the signs and symptoms of asthma, and then we go ahead to diagnose asthma in children.
Okay, thank you so much, Dr. Helen. So as I said last time, that asthma is this is a medical diagnosis. What does it mean? It comes from a Greek word called azen, which means to pant, to breathe heavily, So it is weird. So the term, and when people hear asthma, they know it's a weird disease, and nobody ever wants to told you have a weird disease. So, and that affects how people perceive it. Okay?
And actually, most people don't want to ever hear that diagnosis.
Yes.
And I see so many health workers also try to run away from the term. We try to dress it into allergic cough, hypersensitive airway, and so many other fancy terms. I don't know why we are scared of saying asthma.
I have actually tried in my practice. I've tried both ways to see if I said your child has chest allergy, what is the response? What is the facial expression to the parent They'll say, yeah, I think so. I think so. My child, this cough must be allergic. I thought so. Then I say, I think your child has asthma.
You're like, no, we don't have it in our family.
No, we don't have it. So, and I understand them because it is how it feels, how it sounds. Asthma, what is asthma, you know? It is a weird term. So, but it basically means chest allergy.
Yes.
So I just tell them, asthma is a medical diagnosis, chest allergy is the layman term. So it means the same. And then they're like, oh, okay. So basically it means that your airway is hypersensitive. You have this gene, this blueprint, like we said last time, that is in your blood, in your airway, that if you are exposed to a given environment where there's this stimulus, this thing, particular thing that makes you to be overly reactive, then you start showing symptoms. Okay? So that gene might be dormant. So it's not surprising that people will say, there's nothing like that in our family. It is possible that the gene has been quite dormant for generations. And then the unfortunate part is that this particular generation is expressing this gene. Okay? So if you're exposed to an environment where maybe there's dust, there's smoke or tobacco smoke, fumes from these funny cars, even smoke from burning of different, substances, fumes from perfumes and, detergents, and, pollen, anything in the environment that will cause your airway to overly react, you're overstimulated, produce mucus. There are changes that are undergoing, and those changes, last time I said, we call them inflammation. So, and it is something that is continuous, it is ongoing. It is not sudden and stops and that's it. No, usually it is ongoing. And the reason I'm emphasizing this point is because that when we come to treatment, we must handle that process of inflammation.
That ongoing process.
That ongoing process, which we may not see with our naked eyes, but at the level of the airways, it is happening. So if tomorrow you go into this cold environment, may clear your voice, you cough a little, that shows that something is happening to your airway.
True.
Something has stimulated your airway to overreact. And that process of overreacting is inflammation.
Just a little bit of a question. Way back, asthma was not that common. Why is it that it is more common these days as compared to the previous 10 years?
Helen, I could say maybe two things. One, because our knowledge level has improved.
Okay.
So people are now aware that the so-called, used to be called allergic cough, is asthma. So we are now more alert, we are more equipped to diagnose it and treat it. There has been a lot of improved technology and innovation when it comes to diagnosis and treatment of asthma. So now we have the capacity to diagnose, but also to treat. But also, number two, there has been a lot of changes in the environment, especially when it comes to our pollution levels. Environmental pollution is
much higher than it was
So
before.
you find that more people are now susceptible because of the pollution, the things we inhale on a daily.
So we are awakening the gene more than it used to be.
Exactly. Yeah.
Okay.
So I think basically that could be the reason why we're seeing more. And by the way, majority of the cases are undiagnosed.
True.
Still undiagnosed, But even the few that we have diagnosed, majority are not well treated. They're poorly controlled.
Because we are running away from the diagnosis.
I know.
Thank you very much, Dr. Elizabeth. Now, let's dive into the signs and symptoms of asthma.
Okay, so as I said, remember this is a process of inflammation. The airway, we mentioned about that irritation you get, is going to evoke certain changes in your airway. So there's going to be narrowing of your airway. as a result of that inflammation, then there's going to be restriction of airflow. So the irritation will cause you to cough. Because you know when you have something in your throat, you want to cough. So
automatically
if that is constantly and is over stimulating you, the stronger the reaction, the more the cough.
The more you're going to cough.
You're going to cough, and you cough and cough. So this cough in asthma is quite characteristic. It's a dry cough most of the times, and it tends to be irritating, dry and irritating.
Do they sometimes vomit?
Yes, so because you know there's that cough reflex, so it also triggers a vomiting reflex. So they tend to cough, although not all of them. So there's that cough, which is quite unique. And this cough, most times, it will be, you look at the pattern. When does it occur most? You find a child who has been well, without a flu or a cold, they are playing, over-excited, and suddenly they start coughing. And you're like, what has happened? This was a normal child.
Because they've gotten an irritant at a time.
Exactly. Or excessive emotions. Or you find a child who has been swimming, they went swimming and they've been in the pool several hours and they come out with a terrible cough, which they never had. Or this is a child, they are well during the day when it's warm, happy, but late evening towards early morning, maybe like mid-morning, rather early morning, and maybe like around 2-3 a.m., they're awakened by a cough and they start coughing. So
actually, most parents come to say this cough starts at around 3 a.m.
I know.
That's what most parents tell.
And some will say he's okay during the day, but in the evening, at night, and early morning, that's when he's coughing. So that's an indication that maybe coldness, you know, cold air would be a trigger to this child. Or when it rains, and now that, you know, it's a season for rains, you find more people coughing and you have people wheezing, okay? So cough, that's characteristic cough. Or someone gets a cold, and ideally, if, as you mentioned, a child, normal child on average, they can get a cough every month. Every month, yeah, and it is normal. Within a few days, they're okay. Yes. That's expected, because that's how they sensitize their immunity and build their soldiers to fight. But if this child, even after this bouts of flu or cold, they continue to cough for 3 weeks, for 4 weeks, they're happy, running around, but they're coughing, that's not normal. That's no longer the viral flu the common viral cough and flu. Yeah, it is more than that. It means that this child, this flu that came, it has awakened up the allergy. So the inflammation, the injury to the airway, now it has triggered the inflammatory response that I talked about, and hence the cascade of events that are happening. So that type of cough is something to suspect and question. And then also about difficulty in breathing. Child has been well, and then every time they are coughing or they get a cold, it ends into difficulty in breathing. And then sometimes, unfortunately, you find this particular child will be treated for pneumonia every time. And yet they are not improving. Sometimes a parent comes with a pharmacy of drugs. I know, very unfortunate. And they're like, I've used this. They give you like 5 antibiotics they've used, and the child is still coughing. The child I saw yesterday had been, they're used to getting intravenous medications. So it was like part and parcel of their life. So the mother was even ready and said, every time he gets this cough, he even tells Mommy, don't go anywhere today, because I'm getting a cannula. So sad, you know. So like every time the cough comes, cannula. Cannula was... But was it even helping? It was not even helping much. So until now, when this boy comes, like, so am I getting cannula today? I said, no. You know, so it's some people, because of the difficulty in breathing, they think it's pneumonia. The lungs are sick. Okay? Sure. So they're always in and out of hospital receiving wrong medication. Then chest tightness, for all the children who are able to tell you that I feel tight in my chest. Pain. Yeah, I feel it's paining, it's heavy. And then you see them leaning forward, you know? Trying to catch a breath. That's a sign that maybe this child's airway is quite tight. Narrowed, getting tight. Then wheezing for some children, and majority of the children. There's that abnormal sound, because remember I've talked about, I came with something, my goddess, to explain. So last time I talked about the normal airway, which is open, pinkish and narrow. So when you have allergy or asthma,
it becomes narrow and red,
swollen and red, and there's airflow restriction. So if you don't do anything, then it will get to this. So this is narrow, very narrow. There's mucus, and at this point they are wheezing.
Okay.
There's that sound that comes because air is trapped, you know, into the airways. So they wheeze. So if you're lucky, you can hear an abnormal sound coming from the chest. So that is wheezing. Although you can have a chest that is quiet, they're not wheezing, but actually they are asthmatics.
And actually that is more dangerous.
Yes, and you might find that it's only the cough that will
tell you that
this
things
is
are
a
going
diagnosis,
wrong.
not necessarily wheezing. So you don't have to wait for wheezing for you to diagnose asthma. And most times, actually, it's also a history of asthma in the family. So we tend to ask, especially if there's a first-degree relative, like, you know, brother, sister, daddy, mommy, if they have a history of asthma. So those are the few symptoms that we use, you know, in history. We look at the history before we can do the tests, which tests are also for a few children, older children who are able to follow instructions, blow in the machine, and we measure their lung capacity, their capacity of their lungs to inhale air and exhale air and push out air within a given time.
So in other words, you're clearly telling us that asthma is mainly a clinical diagnosis. It is
That's
from
right.
proper history and examining of the
not
patient.
X-rays, not doing images and these radiations to say, you know, I've seen children who come and say, can you do X-rays? Can you check? Do any images? And they feel disappointed if you tell them, no, there's no need to do it. So it is a clinical diagnosis. We listen from history, how the child behaves, and then we also listen to the chest to see whether there are wheezes, how is the air entry into the chest, and all that.
Okay, thank you very, very much, Dr. Elizabeth. You clearly explained how easy is it to diagnose a child with asthma. I believe even our parents out there can easily diagnose their own children, can easily tell whether their child could be having asthma or not. However, do not diagnose your children. Please come into the facilities and let the health workers assess your children. There are other causes of chronic cough in children rather than asthma alone. Yes, thank you very much. Let's come back to the pediatric voice after the break.
Bethany TV for health. Are you ready for this good news? You can now watch Bethany TV on Yo TV, AfroMobile, and Airtel TV apps. Yes! Catch the finest programming prescription for everybody, wherever you are, whenever you are. Bethany TV for health. Relieve the day's stress. Great inspirational music. Catch up on the latest trends, entertainment, health, current affairs, and Christian events. Don't miss out on the fitness chat with Ronette. Lots of cash and prizes to be won every day. The Sunset Lounge. A good, healthy evening with Prince Nick and DJ Pius. Bethany TV for health. Bethany TV for health.
Out for us. Fixing our eyes on Jesus, the pioneer and perfecter of.
Introducing Medical Minds with Dr. Andabati.
And these tubes can be so delicate that sometimes they get damaged. Some people have gotten the damage because they have undergone some operations. So damage to the tube system is one of the big problems we also do see.
The groundbreaking show that takes you behind the scenes of the medical minds.
You will explore cutting-edge treatment and technologies revolutionizing reproduction health.
Now, in retrograde ejaculation, we get damage to the junctional valves, which I could say.
Learn about the science behind fertility, contraception, and emotional journeys that several women trek.
Every Sunday, 8 p.m., live on Bethany TV. Bethany TV, for health.
Welcome back from the break, and thank you for watching Bethany TV for health. And we are on the Pediatric Voice, your weekly plot where we discuss the different childhood conditions and how best to improve the quality of lives of our little ones. Remember, a healthy child amounts to a healthy youth, adult, and eventually a productive nation. Don't forget that the biggest population of our country are less than 35 weeks. In other words, we have lots of children. So if we can take very good care of them, that means we will have a better nation and a better productivity. And remember, we are targeting a middle income state, and part of good health. Good health is part of the things we have to do to make sure that we reach that middle income state. And maybe one time we can also dream of a first class state. Yes, and this week we are discussing asthma in children. We are having Dr. Kutamba Elizabeth, who is a pediatrician at Health Haven Clinic in Bukoto, and I'm your host, Dr. Helen Namsoke. Please feel free to send in your questions. That is on YouTube and Facebook. That is on Bethany TV Uganda. Call in your colleagues to watch, to share, as well as like. And feel free to watch us on live on GoTV, that is channel 841, and free to air, that is channel 170. And for those of you that get to miss, follow us on YouTube, watch, share, subscribe, and so much more. And call in others to watch and learn more about child health. So Dr. Elizabeth, before you broke off to the break, we clearly diagnosed the children with asthma. And you see from your discussion, looks like a lot of them are hindered by this inflammatory process, by the chronic growing process. So what can we do as parents out there to make sure that our lives, the lives of our little ones are well, so that our children are living to their full potential, and as we mothers can settle in the boardroom and be productive?
That's right. As I mentioned to you, the hallmark of asthma is inflammation, chronic inflammation. So if you want to optimize treatment, we must deal with that inflammatory process. And of course, when we want to treat asthma, we want to first of all classify it and say, is it severe, is it mild, is it moderate? Okay? So moderate asthma, mild asthma, or severe asthma. So when we review this child or this patient, we want to classify them first of all and see where are they. If it's a mild, it means maybe this person gets this episode once a year, once in 6 months. If it's that's maybe mild intermittent, meaning it's on and off.
It is once in a while.
Once in a while, and you know, sometimes they may not even, the parents may never even notice. You know, they'll say this cough is once in a while, but when it comes,
it is really bad.
It's really bad, you know. So that is mild intermittent asthma. So how we manage that is different from how we manage if it is persistent. It is a cough that's relatively almost there every like 3 months. You know, almost every month. That's moderate. And maybe severe, almost every week. You know, or maybe twice a week. Child is always coughing. This cough wakes them at night, almost every week.
Almost every week they have that day they miss school because they were coughing too much, they were not comfortable.
So the reason we classify them, it guides our treatment, how we are going to treat them. But whatever treatment we give, there are key things we want to achieve. One, save a life. If it's a life-threatening issue, because asthma can be life-threatening.
True.
It can be an emergency. Imagine you receive this child who is not breathing, the oxygen levels have dropped, they can die. That's life-threatening. The chest is quiet. So we want to save life. Number two, we want to improve the quality of life of this child. Give them a comfortable and happy life. Let them carry on with their daily activities. Let it be sports, playing, swimming,
singing.
Yeah, singing. Let the child be. Children are supposed to be children, you know?
True.
But you cannot say, no, he can't play. When he plays, something happens. No, he's not
You can't
supposed to
cook.
swim. You know, no, he's not, you know, that's not being a child, and that's restricting this child's activities. So we want to make sure that we improve that. And of course, we want to maintain or prevent severe disease, you know, what we call sometimes exacerbations. We don't want this child to get worse and worse and eventually get difficult to manage. So having said that, it's a partnership. It's a partnership between us, the health caregiver, the child, who is the patient, and the family or the caretaker. So we must make decisions together. So if I tell you, look here, the child has asthma because of A, B, C, D. And this is how we're going to manage. Let's have an action plan together. We're going to give this medication for this long period of time, and then we shall evaluate. We assess and reevaluate. We monitor. That's the other important aspect.
So it is not a one-off that I'll get my medicine, go sit at home
Not at
and
all.
take my medicine, and whenever it is finished, I go to the pharmacy and
Not
refill.
at all. Therapy is okay, but monitoring is important. Because in asthma management is what we call a step ladder approach. It's like climbing a ladder. You don't start from up.
We start way
Baby
down.
steps, you know. So even the drugs, that's how we manage. You start down. If there's no response, go to a second level. If there's no response, we go to the third level, or even the fourth level, or even the fifth level. If we reach somewhere and then we realize, oh, we are doing well, then we start coming down, step ladder. Let's reduce the dose, let's adjust this, let's remove this drug, let's maintain on one drug, or let's even go off, you know? And then we monitor together. So follow-up is important.
Okay.
No matter the medication, no matter what. So it's a partnership. Patient education is important because they must understand the triggers. What is it that is in this child's environment that will exacerbate or that will cause this child to overreact?
You know, there is that meme that goes around on social media, on TikTok, of a lady who was complaining that her asthma is not improving, and yet she's using the drug.
Oh, yeah, I
the
saw
puffs.
it.
And then I asked her, how are you using the puffs? And she was spraying it, you know.
I know, I saw that, I know. You know, and those are the issues that you're able to pick out. If the asthma is not improving, when we follow you up, say, is it about the technique? How are you using the inhalers? When I talk of inhaler, by the way, I came with something so that our members can know that when I talk of an inhaler, it is something like this, you know. So they get the drug. This is a can. They put a drug here. It is in vapor form. Okay,
True.
it is pressurized. So they create this chamber where they fix it so that it's easy to deliver. Remember, the problem is not in the blood. Like people
is in
come
the
and
lung.
say, it is in the airways, you know. People say, I think the issue is in the blood. Or I think there's a neighbor who had cough. So I think this child could have picked the asthma from it. It's not contagious. It is within your airway. So this medicine was designed so that it delivers the drug direct into where the problem is. So gone are the days when we used to have to swallow tablets.
Ventolin tablets.
Yeah, so they have to go into the blood, the
Aminophylline
liver,
injection.
you know. By the time they reach where the issue is, it's taken so long and with so many side effects.
But you need a very small dose.
Yes. So technology has improved, you know. It brings this drug into this chamber, and that's what you need. So now, depending on the, so when I press, you can see what comes out. It's vapor, and that's what you breathe in, and it helps. So technology has improved depending on the the age of the child. There are different gadgets, whether it's an adult, an adolescent, or a baby. Because even babies, we diagnose asthma even below 5 years.
Yes.
As young as 2 months.
True.
A 2 months old can have asthma,
Yes.
depending on what I've described. You don't have to wait for them to be old to diagnose asthma.
Actually, so many people are hesitant to diagnose asthma for children less than 1 year.
I know, because it's quite tricky. You must be confident. You must follow them up and exhaust all those factors I mentioned for you to know that I think this is likely to be asthma. As it's a journey, you walk with them, you monitor the child. If a child, I usually tell my patients, like, if a child gets 2 episodes of wheezing in a year, that is asthma until proved otherwise. More than 2 episodes, because why? If it's a viral wheeze, why is it repetitive? And especially when we nebulize or give an inhaler and the airway is open, that's also an indication that, oh, there was broncho, there was airway narrowing and restriction. And most times when we give these inhalers, it opens up. So in managing these patients, those are the fundamentals. But there are drugs we use. Pharmacology, or the drugs come at the last. Because if we don't educate you on how to use the inhalers, if we don't educate you on your environment, how to control your environment, then we are likely to fail even with the drugs. So the techniques matter, and there are different techniques on the market we use, okay? So from the age of 6 years and above, for children who can follow instructions, and we have educated them, they have understood that they have a chest issue, especially because of their sensitivity, and they need an inhaler for them to continue working well, playing well. So we teach them. So there are those gadgets that have been designed to improve management of asthma. We call them spacers. Unfortunately, I didn't carry one to show, but in the documentary, there were some gadgets that were shown. So those spacers can be used to deliver the medication very well. Because as I mentioned, remember this, if you open the mouth and hold, as you press, a child cannot follow instructions. They may even stop breathing and they open their mouth and the drug is out, you know?
True.
So science has improved that. So they use a mask to put and cover the mouth. Then there's this funnel, which we call a spacer, and the drug is pointed at the end. So you press into the funnel while the mask is there. The child can breathe without any difficulty. You're not worried that they're going to push the mask away or they're going to waste the drug. So then you press the puff and they breathe in comfortably, so that you increase delivery of the drug into the air where the problem is. So now, as I mentioned earlier, we want to address the inflammation, but also give quick relief. Remember, there's airway narrowing, So we have narrowed airway, and there's inflammation
happening.
We want to do 2 things. One, to increase this space,
so that the air easily flows in and out.
So to expand it. And there is a drug we give. There's an inhaler, which we call a reliever. It relieves the obstruction or the narrowing. So it helps to open up. So drugs like Ventolin, and those are short acting. So they open up so that you can come back here, okay?
To the wide space.
But then they do not deal with this inflammation I talked about. So then there's another type of inhaler. For it works on this inflammation. So in some cases, especially for children who have persistent symptoms, we need to combine the 2. We combine the one for inflammation and then the one for relieving the obstruction. So that we go back to the normal lung and windpipe. Exactly. Because if you don't do that, then the air gets more restricted and this child can hardly breathe. So you find you need more time, more energy, more effort, more resources to work on this airway back to this.
Thank you.
And we need to control that. For us to maintain that open airway, we have to give this treatment for some time. Remember, I said that this process is ongoing. It might go on for days, weeks. By the time the child shows symptoms, it has been ongoing. So to reverse this, we must also treat for longer. I usually tell my patients that for you to move from here to here, it's not going to happen in a fortnight.
So actually, what I've seen happening, most of the time they start off with the inhalers, the control and the reliever.
Yes.
Nicely, but when they realize that the child is no longer coughing,
they stop. And within a few days, they come back. So we have to maintain this airway to be wide, and by removing this inflammation. So it is the doctor, and that's why in follow-up and monitoring is important. It's a doctor to say, oh, okay, I think we have moved from step 1, step 2. We're doing well.
Let's
This
go back
child
to step
has
1.
taken 3 months without an attack, 4 months, 6 months, a year. Oh, and then say, oh, doctor, so is it okay now if I can stop? If you're giving 2 puffs in a day, say, okay, let's give 1 puff. From 2 to 1, we monitor. And they are fine, say, okay, let's take a holiday for now and see what happens. You know, because we want to maintain this airway pattern and remove the inflammation.
So, Dr. Elizabeth, the public out there is so scared of using inhalers.
I know.
Do inhalers actually cause asthma?
That's a very important question. Do they cause asthma? Can you get addicted? The question I get is like, my child will get addicted to these inhalers.
Yes.
That cannot happen. And I usually tell them the reason why you feel that you can't let the inhalers go, it's because they make you feel better, you know. So there's nothing like addiction. There's nothing like you get asthma because you're using inhalers. In fact, the inhalers help you to live a quality life, because you imagine you have moved from here to here. And the reason I think they feel that, they know that when I use the inhaler, I feel good. But the day I say, no, I'm not going to use these inhalers, I will get addicted, then I don't, then something will happen.
So what usually happens, I think they stop them at a stage when they are not yet ready to taper.
That's right.
To reduce
the dose.
Instead of reducing the dose, they just stop.
That's true.
So they get rebound symptoms.
Exactly. And then they are worse, and you know, so they feel, you know, now I'm worse because
I stopped.
Yeah. But also because they feel better with the inhalers, so they feel that they're addicted. There's nothing like addiction. I usually tell them, like, for example, the reliever inhalers. When you're coughing and you're wheezing, you use. If you're not coughing and wheezing, you don't need it. Why do you have to use it? You need it, you use it because you need it. But if you don't need it, you don't use it. Okay. But then for the anti-inflammatory ones, the ones to control the inflammation, we need to first control for a long time. Because like now, it is raining. We're not going to know how long it's going to take. We can't say now it will not rain, tomorrow it will be shiny, and we don't know how you're going to react. So it is better to first control for a longer time until your doctor and you agree together, like now, let's try to taper the dose and see.
Is there a role of antibiotics in asthma management?
That's a very important question also, because I feel it's our duty as us, the healthcare providers, to know that this is asthma, this is pneumonia. Because most times these children are misdiagnosed. They are diagnosed for pneumonia instead of asthma. So you find that there's a risk, because any fast breathing, cough, that is pneumonia. So people are stuck to that. So you find this child is going to be given unnecessary, irrational use of antibiotics for their asthma, instead of requiring these reliever and controller medications for their asthma. So, and in the long run, what happens? You're pumping antibiotics into this child's system, they're developing resistance, they're getting a weakened immunity, it puts them at risk of acquiring more colds and more coughs. So it's like they're in and out of a hospital, and their asthma actually exacerbates, it worsens. So these are children that end up in ICU, these are children that end up being in hospital every day. They are not sleeping well, everybody is stressed, and of course weakening their immunity further.
Thank you very much, Dr. Elizabeth. Last question. When it comes to use of steroids, you know, some parents even have packets of prednisolone, packets of dexamethasone within their homes. So whenever they hear a little what? So we've had children with serious side effects of steroid use, you know. The question is, do our children need a steroid, prednisolone especially, and dexamethasone all the time? They get asthma attacks.
Now, that is very important, because steroids, as I mentioned, these are drugs that are used in inflammation. They control the processes we have discussed. They have a role. In fact, even the inhalers for control, they have inhaled corticosteroids. But they are measured and they are given for a specific time, and they have been studied and found to be safe because of the absorption levels. Because remember, they are going into the airway direct. So they are not going to go through the blood and, you know, and then back to the liver, then again to the lungs. So the risk of side effects when you compare the prednisolone compared to the inhaled corticosteroid, it is much less. It's higher for steroids that you swallow, like prednisolone, Dexa, compared to those. But nonetheless, there is a role where we give oral drugs, steroids like prednisolone, to manage asthma, especially when it is a severe form, where this child, for example, has been on inhalers, and for some reason they are not improving, and maybe they got an infection, and for some reason they have ended up in hospital with severe breathing. So those, there is a role. It's only the doctor who knows the dose, and most times when we give the steroid, it is for a short time, usually 3 to 5 days. We never exceed that. It's a known dose and for a short time. But the habit of every time this asthmatic coughs and you give a steroid, much as they feel better, it is risking them to get severe side effects like diabetes, like hypertension, name it. And so I would really encourage viewers or our patients, let that role be given to the doctor, the primary caretaker, the person who is specialized in children, to know that this is the right dose of a steroid I have to give, and it's for a short time, and I have to monitor this child.
Thank you, doctor. You've heard it from the expert. Please let steroids only be prescribed by the health worker. It is not your role as a parent to prescribe steroids to your child, because you risk giving them high blood pressure and diabetes and so many organ failures associated with prolonged steroid use. It is only the health worker that knows when to give and to which dose they should give your child of steroids. They are very important drugs, but they are actually very dangerous drugs, and yet they are so cheap and it's so easy to access in our setting. Now, Dr. Elizabeth, as a parent, as a mother out there, when my child has an asthma attack, in a second, what can I do? I'm assuming that this child has been diagnosed with asthma. Yes.
And you have the inhalers, and the doctors should be able to tell you. That's the action plan that I've talked about, that we plan together and say, if a child is breathing badly, they're in an attack, they can't breathe well, they have chest pain, they are wheezing, you increase the number of puffs. For example, if it's salbutamol or Ventolin, depending on, again, on the age of the child, you have to give the specific puffs that the doctor has told you. For example, if you are giving, let's say, 2 puffs normally, and this is a severe attack, you can even, depending on how big the child is, you can even give from 4 to 6 puffs at a time, you know?
So we don't wait to reach the facility.
Don't wait. You have
we
the
can
puffs,
start the care at home.
Exactly. You puff the child. If there's no response, after 30 minutes, puff the child again as you make your way to the hospital. For the parent that doesn't have an inhaler, is there something they can be doing in the meantime? When a child is wheezing, they are coughing non-stop, you can do home remedies as you plan to move to the hospital. Keep the child warm, give them warm water, a warm drink to take, you know. If there is any antihistamine, you can give, like maybe a cetirizine or whatever to reduce secretions, but make sure at least they are kept warm. Don't give them cold things. Don't interfere with their airway. Don't put things in their nose, like they put sometimes these onions and whatever, rubbing everything, and those strong fumes can easily even worsen the exacerbation. So keep them warm, give them warm water. If this child has been on their medications or they have not used the inhalers for a while, if you have an inhaler, use it. But if you don't have, do the home remedies and work your way to hospital as soon as possible, and call your doctor. It is important to make a call to your doctor who can always guide.
Thank you very much. So in a minute, what is your take home about asthma care in children?
My take home is that childhood asthma is real. It causes morbidity. It can also cause death. It is not a weird disease. It is just allergy that is common, and especially in this season when it's raining, there's a lot of dust, there are fumes, the environment is polluted, and it should not be surprising that some children are diagnosed with asthma for the first time, even if there's no history of asthma in the family. It is probably the gene has been dormant, and this is the time that it is just waking up. So it is important to partner with the doctor, the family, so that you know the right steps to take in management of asthma. If we do not manage asthma, it will eventually cause airway restriction and eventually cause complications in adult life. But with good interventions, this child can have quality care, quality life, they can play, they can participate in their daily activities. So let's not restrict children from play, from doing any normal activities that a child should do because of asthma.
Thank you very, very much, Dr. Elizabeth, for teaching the world about asthma in children. And thank you, dear viewers, for tuning in to Bethany TV and the Pediatric Voice. And this week we had a clear discussion of asthma in children and how best we can manage control to make sure that our children are safe, they can enjoy their full potential, as well as manage the acute phases of asthma, what we may term as an attack. Maybe to remind you that we have asthma clinics nationwide. The Lung Institute, the Mlago Lung Institute, has taken up an initiative through the STAMP project, and they are teaching pediatricians all over the country and medical officers, or clinical officers all over the country in all regional referrals about asthma care. So if you see you've had the signs and symptoms, and if you suspect your child could have asthma, feel free to reach the nearest facility, especially regional referral if you're upcountry, and the different health units. For those in the Kampala metropolitan area, visit pediatricians. Let's you have a proper diagnosis. Let's be sure, are we dealing with asthma? Remember, all asthma wheezes, but not everything that wheezes is asthma. So there are other reasons as to why the child may wheeze when they may not have asthma. So let the health worker tease this out for you. Let's have a proper, is it asthma or something else? If it is not asthma, they'll go ahead to investigate your child to find out what exactly is happening with your child. If it is asthma, they'll have a proper management plan that you're going to follow between you and a health worker to make sure that we give a better life to your child. That is it we had this week on the Pediatric Voice. Till we meet next time, where we discuss different conditions of our children. Remember, if you take care of your car very well as it is still new, you are likely going to enjoy the ride. If you have a good mechanic, good fuel, you're going to enjoy the ride. The same applies to our children. Let's look at it synonymously with our new ride. If you take very good care of your little one from the start, you give them the right medicines, the right facility, the right feeding, and the right care, you are going to enjoy the livelihood of your child, and they'll grow to their full potential. That is it on the Pediatric Voice. I've been your host, Dr. Helen Amsoke. Till we meet next time.
Bethany TV for health.